what happens to this poor woman is somebody will say, oh, yes, but, it really is a true major depression. Here's an antidepressant. Very rarely does anyone think about menopause because she's in her mid-40s, not in her 50s, and she's still got a period, and her body is not affected. She doesn't have hot flushes, nothing to say there's something else going on. That all comes at about 8 years later. So that's the other message to get across. Menopause transition is about a 10 to 12 year process. It's not a quick process.
All right, so welcome Jayashri to the All About You podcast. Obviously you and I have met before, but it would be lovely if you could tell my listeners a little bit about who you are and how you've got to where you are today.
Thank you very much. And I'm delighted to be here with you today on your podcast. So I met Dr. Shauna Watts at a recent conference on women's mental health. It was actually the inaugural Asia Pacific Women's Mental Health Conference, and it was held in October in Melbourne. And I met Shauna and a whole range of other fabulous women who are working to improve women's mental health. So that's my bag, women's mental health. I've been working in this area for the last 30 years, and I've been working in all kinds of different ways and on different parts of the whole big topic. But look, I think my story really started. I was always going to be a doctor. I always wanted to be a doctor right from primary school onwards. So I'm delighted that I was supported along the way by some fabulous teachers and secondary school, and I got to do what I wanted to do, which doesn't always happen for everyone. So I'm one of the fortunate ones. I went to Monash University, and I don't think I've ever left. So I'm a professor.
You obviously like it.
Well, I've been there since I was a medical student, first year medical student, 1976. So here I am still in 2023, and I'm a Monash University professor. And I have done a lot of other things in the meantime. I've set up, this is the third research centre that I've set up. No, fourth research centre that I've set up. But we have a particular focus on women's mental health. And that started when I was a training psychiatry registrar. This is now ancient history. So I was training as a psychiatry registrar, and in those days there were the big asylum type hospitals, big walls, all of that, completely away from everybody, and no one knew what was going on. So it was, you imagine that sort of setup.
I worked in one of those, and I worked in one of those in Northern Ireland.
Yeah, not good. But at the time, one of the things that happened is I was this brash young registrar, and I think, I was already wanting to buck the system. I didn't like the system, and so for that I got punished a lot. So they thought they were punishing me by putting me in the back ward, the women's ward, and it was where women had been patients for the last 20 years or so. So very persistent illness, particularly schizophrenia. It was the best thing that could have ever happened to me in my career, because these were women who I still to this day believe were somewhat neglected by the system. They had been admitted with postpartum psychosis, postpartum depression, many of them, not all of them, but many of them. And some even had described that, really the mental health problems began with the menopause and so on. So I had, no one was interested in this, in the welfare, particularly of these patients. I mean, yes, they were sort of, fed and given the same medication over and over again. But there was nothing innovative going on there at all. And I really learned a lot by talking to the women and spending a lot of time. And this pattern emerged that many of the women described some kind of reproductive event that then triggered the psychosis. Wasn't always the case, but I would say at least 60% of the women had something like that. So, and I was also appalled by all sorts of things that I saw there. I mean, I just thought this is just terrible. That, there wasn't individual private rooms. There was the dormitory style. I mean, that was just awful. And the women were all wearing kind of grey smock type outfits. It was just terrible. So I vowed that I wanted to do something different for women with mental health from that point. And the biological side of me, the interest in the hormone research, was born then, because I thought that we need to follow through the clues that the patients were telling us their stories. And then I also wanted to do something about the service delivery and the structure and all of that. Also thought, the medical care was lacking. There were women who had urinary tract infections and things like that just hadn't been attended to either. So, all in all, from that terrible Dickensian kind of setting, I was absolutely inspired to do something. And, I met with a lot of resistance, because people were like, nah, what are you talking about? No, women's mental health is not separate to men's mental health. It's all the same. We need to innovate things if you want for everybody, etc. And I said, yes, this is a way forward. We can actually look at the gender specifics. So I pursued different types of research. I did pursue neuroendocrine research with the hormone side of things. Fortunately, the person who was my PhD supervisor was not keen for me to do women's mental health and neuroendocrinology of that. And he tried to talk me into other things. And I kept saying, no, I really want to do this. And look, we could do this. And I had all, planned things that I could do and how, it would work. So I never went with just, I want to do this and that, full stop, because that was not going to get anywhere. And fortunately, at that time, in 1991, there was an edition of Schizophrenia Bulletin that came out that was all about women and the gender differences in schizophrenia. So I wrote handwriting letters in those days. I wrote to, sounds like an ancient history story. And anyway, I wrote to the key scientists that were in Germany, and also that was Professor Heinz Hefner. There was another famous psychiatrist, she's in Toronto, Professor Mary Seaman, and then also in Boston, Professor Jill Goldstein. They were the three big names at that time. Later on, there was Professor Anita Rika Rossler in Basel, Switzerland. She actually came from the German group. So I would have said that was it. That was the four big names in this gender work, and particular neuroendocrine work. So I've actually flown across many times in my career to meet with each of the individuals. In fact, I recently met with Jill last year, and it was great fun. So I've been catching up with them intermittently, but by kind of default, they saw me as the Australian clinical trialist of their theories. So none of them had really embarked on clinical trials of estrogen in schizophrenia, and that's what I did to start with. So that's where I began, and I did lots and lots and lots in that area, refining that and moving forward with that, and showing that, in fact, estrogen has major impacts in the brain, which has been forgotten. It's still forgotten by the average practitioner out there. And, of course, it's a major brain steroid, but we only think of it as, the girl's hormone that is all about having babies and infecting uterus and ovaries. And, of course, it does far, far more than that.
Isn't it funny that everyone, lay people, etc., all accept that testosterone in men can impact, and if someone's very angry, they'll often say, "Oh, he's got so much testosterone," and yet they're talking, and they're just like, no one seems to actually think that female hormones could possibly have the same sort of impacts within the brain. It's very interesting.
Yes, it is. And again, this was, the feminist side of me going, hang on, why are women not given priority, or not, that women's mental health is not seen as a national priority? And it really isn't still a national priority in this country, Australia, but nor is it really a priority anywhere else in the world. So that was the other side of, there's the biology ticking along nicely, papers are being written, and then I translated that into the clinical work, so we can use lots of different forms of estrogen, whether it's the pill, whether it's menopause hormones, treatments, that we were using in the clinic because it's available, and getting some great outcomes. But the other side was still nagging at me. Like, I still remembered the vision of all the old wards and structures, and I kept banging the drum because I didn't see that there was a lot that had really changed. I mean, we did lose the asylums in most of the world. There was deinstitutionalization in the mid 90s, but then there wasn't really anything specific that happened for women with mental health conditions. In fact, in some ways, things got even worse because when women were admitted to the inpatient units, we now have the situation where anyone who can be managed in the community is managed in the community. So it's really only the very unwell who get to be in the inpatient units. And that means when you've got a co-gendered ward with men and women being managed together, you've got very unwell men who are disinhibited sometimes because of street drugs like amphetamine type drugs. And there are assaults, and there are unfortunately assaults on women all around the world. So in the Western world, in Asia, it's different. In Asia, there are clearly defined men and women wards. So I started that campaign to say, look, we need women's only wards. And again, was like, nah, what are you talking about? That's crazy. No one would want to work in. First of all, it was like, no one would want to work in a women only ward. Then it became no one would want to work in a men only ward. And this is not a jail. I mean, all kinds of comments and criticisms and so on. But I kept at it, and the first bit of good news was when a state health minister gave me $300,000, a princely sum of $300,000 to build a wall. So we built a wall in one of the wards at the Alfred Hospital. It was the first time this had happened. And it's not surprising, lo and behold, the women preferred to be in the section designated for women. And there was no chaos in there. Like nurses happily worked in both areas, and in fact loved it because they became specialists. So there were men's specialists as well as women's specialists, and there was a lot of different things that happened. And not surprisingly, the assault rates went down. So this wasn't rocket science. It really wasn't. But it's still.
I think you were metaphorically drawing a physical or building a physical wall, but also the message clearly is that women's and men's mental health are different and do need to be managed differently. And it's not just a case of, reducing the dose of the drug because women are slightly smaller, et cetera, which is probably the way it's been in a lot of specialties. A lot of research is done on men, and then we just translate it, it'll probably work on women the same way. And I think what you have worked really hard to highlight is that is absolutely not the case. It's not the case in lots of specialties, but definitely not mental health.
Absolutely. And you hit on several points there, and that is in fact exactly what has been happening. I'm actually really excited because I think we're at the dawn of a new concept. And it's not a new concept to us in the field who've been banging this drum, but it's almost as if suddenly people are saying, women's mental health is different, and maybe we should do things differently for women. The other really important and exciting part about this is the woman's voice. So I think in all of this, one of the things that kept coming through was it was as if everybody spoke for the woman with mental health conditions. She was not able to speak for herself. And that's just wrong, as well as it's not helpful for anyone. It's not helpful for the clinician. It's not helpful for the woman or her family. So I am really delighted that we're hearing a lot more from people with lived experience, and a lot of our research now is co-designed with women who have lived experience. And I always hark back to that day the days when I met the amazing women in the back ward of that hospital who had so much to say and so much to teach a young doctor like myself, and yet had been completely ignored. And I think that's what is missing in a lot of the weird stuff that we still see, like guidelines that come on down from high, academics in ivory towers sometimes, not even clinician-driven academics or academics who are in the real field of what's going on in clinical psychiatry or mental health. And we get weird guidelines, and it doesn't contain the woman's voice. And I think menopause is one of those areas. Menopause depression is a huge problem for many, many women. And we're in this funny loop at the moment where there's quite a few deniers, which is ridiculous, of menopausal depression. And so they will say, well, you haven't got the evidence, you haven't got a clinical trial that shows that hormone, the estrogen, progesterone type hormone combo that you use in menopause, that it's effective in menopause depression. And we see it every day in our clinic, and so do other clinicians. But that, yes, there hasn't been a clinical trial comparing HRT, for example, with antidepressants. And so the guidelines fall back on antidepressants and a naysay about the causality in that group. The causality is the fact that there's massive hormone fluctuations in the brain, and there's no point denying that. This is happening, and yet we're still fighting this really bizarre situation where guidelines don't take that into account. So again and again, there are new battles to be fought and new people to convince, because at the end of the day, it is the woman who's struggling with her mental health that we're actually trying to do something positive for and with. And the with is the other really important thing. So I'm really excited about the fact that we've got a whole bunch of women with lived experience who are now speaking up loudly, strongly, to say, I want better. And that was what was missing back then.
Absolutely. Can I ask you to explain the subtle differences that you would see between a woman who has depression versus menopausal depression? What differences would sort of make you think, oh, this is maybe not just a straightforward anxiety and depression?
So, I mean, mental health is never nice and clean and straightforward and easy. Never. It's always messy, and many factors go in to make up a mental health condition. But let's look at depression. So, the easiest group, if there is such a thing, is probably the woman who's had no mental health issues whatsoever in her life. She's sailed through, this lucky woman, and she's, had a really lovely early life, childhood upbringing. She's got a nice supportive network. She's got the career that she wants, and so on and so on. Right? So here's this happy woman who, bang, at about 43 or 44, suddenly develops panic and anxiety. And often it's a panic and anxiety that starts this. Then you get the succession of symptoms of, then can be brain fog, and then there can be some just tearfulness, there can be rage, there can be actual sadness. And it's all happening up and down. So, this could happen one week and she feels absolutely debilitated by it, can't get out of bed, can't do anything. And then suddenly, the next week, she's back to herself. So this stuttering course of what we call menopausal depression, which has come out of the blue, with no particular psychosocial problems that are new for her, would be the easiest case in terms of diagnosis of, we should be thinking in the mid-40s that it is the brain steroids of estrogen, progesterone, androgens as well, starting to play up and have big fluctuations, which then impact on the brain chemistry and the brain circuitry, creating this change in her mood and behavior and cognition. So that's the easy case. And of course, what happens to this poor woman is somebody will say, oh yes, but it really is a true major depression, here's an antidepressant. Very rarely does anyone think about menopause because she's in her mid-40s, not in her 50s, and she's still got a period, and her body is not affected. She doesn't have hot flushes, nothing to say there's something else going on. That all comes at about 8 years later. So that's the other message to get across. Menopause transition is about a 10 to 12 year process. It's not a quick process. So that particular woman, I feel very sad about, as well as many others, because she will receive antidepressants and it will have a little effect. It won't be completely useless, but it'll have a little effect. And of course, it has a lot of side effects. And this is the person I see in my clinic probably 2 or 3 years down the track when she's getting to 48. And unfortunately, she's probably gained 20 kilos from the antidepressants. She's blunted, just not feeling very much. She may or may not have other social problems, like the brain fog will not be under control, and so she may have lost a job. She might be enraged at times, and that has created relationship difficulties. And so, you can see all the consequences of not treating this. And it's sort of common sense. It really is common sense. If we think it's a hormone problem, treat it with a hormone treatment. That's as basic as you can get.
And the other important point, I think, is that just because you've got a normal blood test doesn't mean that you're not perimenopausal. I've had so many women come to me. They've seen other clinicians and they said, oh, but they did my blood test and they said it's definitely not my hormones. And it's such a source of frustration to me. In the perimenopause, a blood test is really unhelpful. It doesn't actually really tell me anything unless it tells me that you're already through your menopause. Isn't that correct?
Absolutely correct. And that doesn't help this poor lady, my hypothetical case, because unfortunately, yes, you're quite right. The brain changes that are occurring will not be picked up in a blood sample that's taken from the arm. That's just very crude measures. So that's one thing that it's really important to go, okay, throw away your blood tests. Let's just go back to good old-fashioned clinical know-how and see if we can work out, because that story that she will tell you that it was fine, she was fine, bang, that's not a typical depression story. So we almost need to go back to trust your clinical ear, what you're hearing. And this is important work because you need to spend more time with your particular patient client and actually allow her to tell you the whole story, because she will have all those details about, look, doc, you might think this is a bit strange, but I used to be able to remember mobile phone numbers, which are 10 digits. And now I'm having to write stuff down and I don't understand. I'll go to the supermarket and I cannot remember what I needed to buy. Whereas, just a few weeks ago, I was sharp and I was doing everything. And so there's your cognitive changes. And then she'll probably say, am I dementing? Which is, a real fear for so many women.
Had that a lot. And I also have patients who we live on the Central Coast, which is like 90 minutes from Sydney. A lot of these people have grown up in Sydney, worked there, and all of a sudden they cannot drive in the city. They're having panic attacks, pulling over in the car. They're feeling like they're going to maybe try and look for a job closer to home, because there's just this real drop in confidence and just this constant anxiety. And then the other one is those women who've maybe had really quite high level jobs, but they feel they can no longer chair the meeting because they actually are just losing their train of thought all the time. And they're often thinking, as you say, they've got dementia.
Yes. And many, many times women have reached, into their jobs or their home situation or whatever it is by doing multitasking. That's a very common female way of operating. And that multitasking may collapse a bit. So instead of being able to do 5 things, she can do 3 things. And that may make the difference between being able to hold down a high-level job as well as manage adolescent children, as well as maintain a relationship and social networking and all the rest of it, look after elderly parents and so on. So this is where the red herring has been, in the sense of, a lot of the time, the woman will be told, well, you're terribly busy. You poor thing, you've got all these balls in the air that you're juggling. No wonder you're feeling stressed. And that's patronizing, because this woman has been dealing with this for, that's not come newly. She has always been juggling this, and this. It's when you get that story of this sudden change. It's not gradual, it's a sudden change. That needs to be listened to with a biological etiology kind of framework, because that is not how somebody who's overwhelmed by tasks will present necessarily. That is the easy case. But the more difficult case is, of course, where somebody has got a past history of some mental health condition. It can be depression, it can be anxiety, it can be PTSD, post traumatic stress disorder, it can be a range of things. And she's been managed very well on maybe an antidepressant or a combination of a few different psychotropic medications, but she's been managed well. She also will suddenly relapse in the mid 40s or even late 40s. And then it becomes, oh dear, maybe the medication's worn off. Maybe we're not, maybe she needs more medications. Maybe, you know, her life is just overwhelming her. And so there's the search for all of that. And again, very rarely do people go, could be menopause in the brain. And it is menopause hormone fluctuations in the brain that's causing this relapse for this woman who's previously been well managed in her own life. So that's the second group, and that's even messier because this is a woman who has a past psychiatric history, and unfortunately, once a past psychiatric history is noted, there's kind of a blinker that goes on, like, you know, there's, let's just swim in this lane. We'll not look in any other parts of the pool, and you know, that's all that will happen, is they'll be fiddling with the antidepressants and so on. And this woman also will receive, you know, a little bit of improvement, but not the wholesale treatment that we're looking for to really help her get on top of these symptoms. So again, the blood tests come out, and as you've said, you know, there's no joy to be found there. In fact, if anything, it puts people on the wrong tram, because they go, oh yes, well, you know, she's fine, it's not menopause, even if that thought has entered someone's head. So we need to do lots of things, don't we? I mean, we need to get rid of those blood tests in the mid-40s, unless you're checking for something else like thyroid function, or, you know, if you're looking for what's the standard blood film or those sorts of things. That's a different story. But don't look for menopause diagnosis on blood tests in a perimenopausal woman. That is futile. And
Yeah, absolutely. And so for these women, I suppose, do you feel like once they start to take hormones, once we get them onto the right treatment, whether it's hormones with an antidepressant or hormones on their own, how quickly would you expect to see those symptoms improve? I mean, I know everyone's different, but on average?
look, on average, if you hit the right hormone combination, the right dose of hormone combinations, it's pretty magical, because I've seen the very rewarding situation where, you know, I'll ask the patient in my clinic to start on hormone therapy and keep the antidepressant the same, because I very rarely see first break of this kind of condition. That'll be the general practitioners in the community who get that opportunity. But I don't get that opportunity, so I will just add HRT to whatever other psychotropics are on board. And then I've seen people come back for a review appointment the next week, and I've walked past them in the waiting room, not recognizing this bright, you know, very excited, happy woman, because the previous week she's been dreadfully depressed and down, and, you know, often raging or in tears and so on. So it can be as miraculous as, you know, just a week. Um, a lot of times, though, you do have to tweak and play with the hormones to, you know, like many times women will come in and go, I think I'm on the right track because I've noticed a lifting in my mood, or I can just think a bit more clearly, but I'm not quite there yet. And so that suggests, right, okay, we need some hormonal manipulation. But, you know, it's really interesting. Very, very rarely, I would say in about 80% of people who have been started on hormone therapy, we get some positive response. Some positive response. But from the magical, complete, you fixed me, you're a miraculous miracle worker, and that makes the doctor feel really good. But, you know, from that to, yeah, I'm just a bit better. I'm not brilliant, but I'm just a bit better. So that whole response rate, I reckon, is in about 80% of the population we're seeing. It's only in the minority where you get nothing, like no response, and that's fine too, because then we need to look further and think again. So I often think, well, yeah, we don't have that magic test to go, this is what's happening. But I'm annoyed with the guidelines that say, no, you cannot use, HRT unless there's blah, 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 hot flushes and this and that and the other. As long as we manage the physical health, and which in a 40-something-year-old woman, you do have to make sure that she's getting regular mammograms or pap smears and breast screening and blood pressure checks. I mean, that's just good standard medicine. As long as we do that, what have we really got to lose with a short trial? I mean, if it doesn't work, it doesn't work, and she can stop it. You can't really do that with an antidepressant. You can't just kind of go on an SSRI and then go, oh, no, I don't like this, I'm just going to stop it. Massive withdrawal problems. So this is easier to manipulate for the woman, and I like the woman to manipulate that herself.
Yeah, absolutely. And what about the other therapies? Do you feel that there's a place for these women to have things like cognitive behavioral therapy or see a psychologist, or are there any other things that you recommend alongside hormonal therapy and potentially antidepressants?
Look, I'm always guided by the woman herself, because I do get that group who go, oh, look, I've done therapy to the eyeballs. Do not, so I'm not going to go there if someone has that. And also, it's almost like, let's try and see if we can just harness your own natural resources and resilience with a biological approach. But of course, I have the luxury of long consultations. And if I've picked up that there are issues, either pre or post, perhaps the marriage is going a bit sour because she hasn't been herself and he doesn't understand, that's a good place to do some preventative couples therapy and so on. So I'm always listening for what is the individual going to benefit from. So I don't like cookie cutter sort of, here's the pro forma. Everybody gets HRT, everyone gets an antidepressant, everybody gets CBT, everybody gets, it doesn't work that way. And, even lifestyle issues and so on. I mean, if she's having problems with her weight, we will delicately and sensitively work with that, because it might have been that she's had a whole bunch of psychiatric drugs that have caused the weight gain. Well, no amount of running around and eating just a lettuce is going to help. If in anything, it's really going to make her feel worse. So, we can deal with those issues in different ways. But we do work in a biopsychosocial framework. So I have capacity and a network of referral sources to help me do that. But it's going to be different amounts for each person. Sometimes it might be very clear that the poor woman is in this dreadful, abusive relationship. So no amount of hormone therapy, no amount of, antidepressants or whatever is really going to fix that, help her in that. So, we'll sensitively and delicately work on those issues. And unfortunately in COVID, in Melbourne being a very locked down city, we had many cases where, I'd hear the call that was from the woman in the toilet, because that was the only place where she could have some space to talk. And there would be, screaming and yelling going on, and we've had to get the police involved. So, it's very much individual based, individually tailored therapies, but driven by the woman herself. I think it is important that we also need to recognize, even with hormones, you've got a big spectrum of how people absorb hormone, estrogen, for example. You can't just go, look, it's got to be this dose, because that doesn't work. And some women have said to me, look, I sneaked on another patch because I just wanted to see if that, and guess what? I felt so much better. And you go, okay, well, that's a dose finding study with an N of 1, but, different people, different absorptions, different rates are needed.
Absolutely. And it's so frustrating as well that within hormone replacement therapy, like in comparison to thyroxine, where one person might get 25 micrograms and another person might get 250, there seems to be, the guidelines and dosages are really very narrow, as if we're all the same, whenever we know that's not the case. I'm definitely still feeling a lot of barriers to HRT around breast cancer. I even was sitting in the hairdressers, and some women were chatting with me, And it was quite interesting because they were like, oh, no, but I can't have HRT because my auntie had breast cancer, or, oh, we've got a family history of breast cancer. And quite frankly, if anyone with any kind of decent sized family, there's probably someone in your family at some point who's had breast cancer. And there definitely still seems to be this real fear of taking hormones. Is that still something that you find in your practice, or do you find by the time you see people, they're very open to it?
I think a couple of things. Yes, I do hear that a lot as well. But then we go into the risk benefit analysis. And of course, if there's mum has breast cancer, a sister has breast cancer, an aunt has breast cancer, grandma died of breast cancer at the age of 40, we're in trouble here, right? So that kind of history, of course, is alarm bells. But when I hear about mum had breast cancer when she was 75, and this is a woman who is in the depths of despair with a depression that is not responding to psychotropic medication. She's tried 5 different antidepressants. People are talking ECT or electroconvulsive therapy, shock treatment. You've got to then weigh the risks and benefits. And that's what I do, is talk to the woman about, okay, I hear that story. We'll definitely keep tabs on your breast health with screening. If need be, if there's more than 2 people, you can do some gene testing. But I really think you should give this a go, because it might have the benefits that you're looking for. It may not, but it might have the benefits, and you can stop it after a couple of weeks trial if you don't like it. Unfortunately, that dreadful Women's Health Initiative study of 2001 is still with us. And, I'm still appalled at how many general practitioners, psychiatrists, other health professional doctors haven't read any more than what happened in 2001. We're in 2023. I'm still amazed and appalled at that. So I don't know how we get rid of that, because yes, that made screaming headlines, but it's all been debunked. And I don't know how we get that message out to women, the individual woman, because it's still
so
there.
frustrating, because when you think about how much in the last 20 years hormone replacement therapy rates of prescribing absolutely plummeted. Like most of us are really de-skilled in prescribing it. Like you have to have an interest now. But the reality is that breast cancer rates didn't decrease. If anything, they're increasing. Yeah. So if hormone replacement therapy was the cause of all this breast cancer, surely if we all stopped using it for nearly 20 years, if anything, breast cancer would be quite a rare thing, which it's clearly not. So it's definitely frustrating, the things that have been really publicized and the media have jumped on, and yet they don't seem to be so quick to jump on the opposite.
It's always that retraction on page 27, but the screaming headlines page 1.
And a little small square that no one reads. I just wanted to touch very briefly. I know it's a difficult subject for many listeners, but I think we have to be open and honest about it. There is a real peak of suicide in women in this age group. And I wonder if you could talk to me about, you're obviously being so experienced. Is that something that you really see and that has been a kind of a consistent thing of women in their sort of 45 to 55 age group? And do you see that improving or getting worse?
I see it getting worse. And as you say, women are at the greatest risk of suicide in their middle years, which is not something that's very well recognized. And you can, it doesn't take much to put yourself in the woman's shoes. She's been fine. Suddenly her life is just ripped apart by what we know, what you and I would know is menopause depression, but she doesn't know that, and maybe her treating team doesn't know that. And then she goes from antidepressant to antidepressant to antidepressant, mood stabilizer, antipsychotic. Someone says she's bipolar. Someone says she has a personality disorder because she's not responding. So therefore it must be her fault. It's just crazy stuff. Anyway, the poor woman in the middle of this is of course feeling hopeless, helpless. They're features of depression anyway, but because of the lack of hope from the treatment, she sees herself as never being any better. And then you get the building onto that I'm a burden to my children. I'm a burden to my spouse. I'm not looking after the elderly parents. What use am I? I've lost my job, so now I'm a financial burden. I don't have the status of being the manager in the workplace, whatever. Loss after loss after loss. And that's when the suicidality sets in. And it's also a feature of this depression because this is a serious major depression. And I've heard clinicians say really dumb things like, oh, if it's menopause depression, it won't be serious. It's just a thing. Why don't we just let it ride out? Well, I said it's about 10 to 12 years of major depression. It's not going to ride out. You can't ride it out. And then you get these comments, every woman goes through menopause, so it'll just go away.
It's natural. It's just a natural part of life. That's another favorite phrase that I want to strangle people for saying. But it's natural.
So this all adds up to the woman also, feeling like, hang on, if every woman's going through this, I must be a real failure, that I'm not getting up and over this. So for all these reasons, suicide thinking sets in. And menopausal depression includes poor self-esteem, and that self-esteem really plummets. And suicidality is, if you take self-esteem, poor self-esteem to its nth degree, that's what suicidality is. It's like, I am so terrible and pathetic and worthless that it doesn't matter whether I'm alive or dead. I mean, awful, awful stuff to feel like your life doesn't mean anything. But that's what happens. And unfortunately, suicide does happen. And then, we have the awful situation of the loss of this wonderful, talented person, the ripples into her family, and, all sorts of horrible, horrible consequences. And what's so sad is, my gosh, if only we could have intervened with some damn HRT back then, we might have been able to save this individual. And that's a terrible coulda, shoulda situation to be in for everyone. So this is why, I'm so passionate, like you are, about getting this message out there, because if it's going to save even one life, why are we holding back? And that's where I'm really annoyed with the guidelines. We could be talking about life and death, and we have in our hands something that might make the difference, and yet we're being told you can't use it.
Yeah, absolutely. And I feel like as well, in so many people's minds, both in the medical community and lay people, there's still this preoccupation that the menopause is something to do with periods, and shouldn't you just be happy because you don't have a period anymore? And that people don't really understand that, yes, of course, not to overemphasize, there's lots of women who do sail through the perimenopause and the menopause, and they're kind of thinking, what's all this fuss about? But the reality is a very significant percentage of women actually find this whole time a really, really big nightmare. And it's just kind of brushed under the carpet like, well, it's natural. Well, to be honest, like, cancer's natural. It's a natural phenomenon, but we still give people treatment for that. Like, there's thyroid problems in theory are natural as well, but we still treat them for that. But, there just seems to be this real barrier that somehow women should be a bit more stoic and just kind of get on with it. And it's hard. I think it is shifting, but I think it's a slow shift.
Well, I mean, I'm much older and I've been doing this for a lot longer, so I'm actually happier that we seem to be on sort of extrapolating the curve. I'm hoping that we're on a fast uptake now of getting this message out there. And I think it's because of the women with lived experience of menopause depression who are speaking out, going, no, I will decide. That's my point. Just, I keep getting told, well, what's the percentage of women who have depression? No, it doesn't matter. Does it really matter whether it's, and I know it's high, but, if it's 65% versus 40%, what earthly difference does that make? If you have somebody in front of you whose life is going down the gurgler because of menopause depression, then the percentages don't matter. What you have in your hands is the capacity to say, okay, what do you think about, we could go this way with antidepressants, we could go this way with HRT, we could go this way with combining them. What do you want to do? It's as simple as that. you know, and I think choice is really critical. So when the feminists, and I'm indebted to the feminists of the 70s and 80s, because otherwise I wouldn't get to do what I do. But sometimes the feminists now are saying silly things like, just shut up about menopause, otherwise you will make it difficult for women to attain the high offices and so on, because they're going to be seen as creatures at the whim and mercy of their hormones, and we want to get away from that. And I think that's the wrong attitude. I think we have to say, no, look, where we are is women have choices. And it's the woman with lived experience who needs to make that choice. And she can be given all the information. Yes, as doctors, that's our job. We provide the latest information. But we stand next to the woman as she makes her choice. And I think that's the critical part. And that is feminism in action, you know, choices.
Absolutely. I wanted to ask you about two younger groups. The first one is, so I personally had a surgical menopause at 33. Do you feel that women who have a younger menopause present differently with their mental health symptoms?
Yes. So there are some studies. In fact, a couple of people here at my centre are doing some work on exactly that. And unfortunately, it's like this sudden onset, and the you know, there's sort of a shock in the brain, as because suddenly the ovary response and the ovary feedback is not happening, or the whole system is changed. So I think it is worse. And then, of course, you do have the psychological factors for the young women who may not have thought about the families or may not have completed having children. So suddenly that decision is taken away from her. There are all sorts of things that happen. But I think, again, biologically, there is a major insult to the brain at this point, which, you know, in natural menopause, it's this kind of curve, but the curve is eventually going down in terms of fluctuations and perturbations of estrogen in the CNS in the brain. Whereas here, you have, you know, relatively high levels of reproductive estrogen levels in the CNS, and then suddenly it's not there. So I think it is worse, and we keep seeing that again and again in the surgical menopause younger group. Mental health is worse.
Um, if we go to that even younger group, potentially, so whenever I was growing up or in my early career, we talked about PMT or PMS, and then I hear this term PMDD. Can you explain to our listeners what those are and how they're related to each
Yes.
other?
And there's a new term, PME. So let me just explain where we're at.
Oh, wow. Okay. We need to get all our acronyms ready.
So this is premenstrual syndrome, is PMS. And that's much more the physical symptoms that many women get prior to menstruation. And it's usually the bloating, it's the breast pain, it's feeling a little bit irritated, it's often headaches, but mostly physical health symptoms. And then the period comes along and the physical health symptoms resolve. PMDD, on the other hand, and about 80% of women of reproductive age have some challenge with premenstrual phase. PMDD, premenstrual dysphoric disorder, and again, this is classic labeling of women's conditions. Dysphoria is mild sadness, whereas what we're talking about is actually a major depression. PMDD is a major depression, and it affects about 10 to 15% of the reproductive age group of women. And it is a major depression that presents cyclically. It may not necessarily happen in, you know, day 21 to day 28, which is that lovely menstrual cycle picture that exists in textbooks alone. Very few real world women have that kind of textbook picture, but it's cyclically. So many women will come along and they go, you know, I'm going along fine, and bang, I just get so depressed. I get really tearful. I get ragey. I can't do anything. And brain fog is a part of it as well. And tearfulness. It's a little mini menopause symptoms. You know, I just, people will look at me in a way and I'll bite their heads off, you know, that kind of stuff. but it will come on suddenly and it will stop suddenly. Now, it may or may not coincide with the week before menstruation and then stop once bleeding starts. Or it could be every 6 weeks, or it could be every 8 weeks. But the feature that you look for as a clinician is the story of sudden onset. Again, it's very unusual for someone who's depressed because they're in life troubles, maybe they've got work difficulties or relationship difficulties. That's not going to present with sudden onset depression. So again, here's the clue. There's a biological trigger that's going on. And yes, it is in women. Some women are very, very vulnerable to even small changes in their brain hormone and then the hormone chemistry interactions. And so that's what happens. The issues here are that, again, this is a serious depression and it can have serious consequences such as suicidality. So we have to treat this seriously. And far too many people, because she kind of snaps out of it, will say, oh, well, just grin and bear it, get over it, or is she making this up because she was fine and now she's not, and then suddenly she's fine again? So there's this kind of attention seeking question mark, and that's all very unhelpful, incredibly invalidating of the woman's experience. And a hormone treatment is often the way forward, and the pill is a good hormone treatment, but you've got to find the right pill, because some pills are quite noxious in terms of mental health, because the progesterone in some pills, the synthetic progesterones, can be very damaging in terms of depression in themselves. So that's the difference between PMS and PMDD. I think they're on a spectrum, but one's at the physical lesser end of symptoms and the other is at the severe major depression. PME is premenstrual exacerbation of a pre-existing mental health condition. So again, just like our menopause lady, the one who's got a past history of depression, and it's usually well treated, suddenly premenstrually it'll just flare up and not be good. So that's premenstrual exacerbation. So, what we have here is a setup in terms of the mini menopause reactions. And then when the woman gets to perimenopause, it all explodes because we know that she's vulnerable to smaller fluctuations. So when the big fluctuations of menopause happen, we know this person's going to be in trouble. So that's what happens there.
Is there a connection or a pattern between people who've had PMS or PMDD and postnatal depression and then potentially issues? So can you explain to me the biological nature of what's going on in postnatal depression?
Okay, so we have to hypothesize that there is a vulnerability to fluctuations in the brain estrogen, progestin, and androgens, and all the hormones that come from pituitary and hypothalamus that lead to those, right? So some women are very vulnerable to even small shifts. Now, we have some leads as to which of these women. We think it's women who have had early life trauma, because if there's early life trauma of emotional abuse, sexual abuse, physical abuse, emotional neglect, emotional invalidation, this resets the hormone axis from a very early age. This is hypothetical, but this is what we think, because when we take the stories, we do find, not everyone, but in a significant number, there's a story of something not pleasant in early life, and that makes this woman much more vulnerable, because there's a cortisol hormone, gonadal hormone reset that doesn't help, because then she is more vulnerable to external stresses and external or internal hormone shifts. So that's one thing that we look for, is a story of early life trauma, and we match that in then looking for PMDD. We look at postnatal disorder, because that's another big shift in the hormones. And this is the classic story is she's had a lovely pregnancy when all the hormones are very high, so her brain is bathed in lots of lovely estrogen, and then there's this crash when she gives birth. And then there's the same woman who then gets to perimenopause and has a dreadful time. There is a gene that's been isolated in PMDD, and it was in 2018, and it's called the E2ESC comb of zest gene. And it's it's an estrogen transporter gene. It's a weird name, but it's a gene that is about um, carrying a vulnerability to estrogen related depressions. But here's the big but: it takes external, so it's a gene environment interaction that makes that gene come to life, as it were, or to be active. So many women can carry the gene, but if she has a nice ride through life, which we hope everyone has, then it's not going to be expressed in PMDD. And I suspect, even though it's not been looked at, but I suspect that that same gene is there in the perimenopause and the postnatal depression group as well, but it hasn't been looked. It's been isolated in the PMDD group. But it goes back to that theory of early life trauma or some other trauma that happens that brings that gene out. And you hear it. Oh, when I was younger, I never had PMDD. And then you get the story of some horrible bullying or even, forced sex or something that happens to the adolescent. And then bang, she develops PMDD.
And is that gene something that you guys test at your research
We're
centre?
starting to look at, it's not commercially available to test as such, but in research world, yes, we're building that in to look at it. But, a lot of the things are, we don't talk about things as just genetic anymore. Even if you talk about diabetes, you don't talk about it as just genetic. You look at what is the gene environment interaction, and this is a really important case of that as well.
So obviously today we've covered the sort of spectrum of female hormones in time, and there's so many other psychiatric and mental health issues that women can suffer from. I really hope at some point you will come back and talk to me. I know that we're actually both quite passionate about hating that name bipolar borderline personality disorder.
Yes.
I hate that
Yes.
name. So hopefully another time we can chat again. But I suppose just to end on a positive note for our listeners, what would be your advice to women at any age along that spectrum who are struggling with their mental health? Because we know there's a shortage of psychiatrists in Australia. There definitely are not enough of you guys. I know every day it's a bit of a battle, and me trying to sweet talk someone to take one of my patients who needs an extra bit of help. So what would your advice be to maybe a woman or her family who are listening?
My
what
first
would
thing is
that
to
be?
the woman, trust your gut instinct. If you think that what you're going through, because many times women will walk into my practice and they'll say, I think it's my hormones. And I'll go, yes, that's really important. Trust your gut instinct because you live in your body. Most women are very good at knowing what is happening and what is different. And so I would say trust your gut instinct. If you think it's hormonal, go and find a general practitioner because that's who's probably going to be your best friend. Psychiatrists haven't come around yet to the idea about hormones. I'm working on it, but we haven't quite got there yet. But the general practitioners are in the best possible position because they're very good at dealing with physical health, mental health all together. But some are still stuck in the WHI study of 2001. So keep shopping until you find somebody who will listen because the woman herself has to be at the center of all of this. And what she's feeling and what she's thinking has to be a big part of the management, and she needs choices, but she needs to make that choice too. So I would say trust your gut instinct. And again, if we can start the message or keep the message flowing that hormones affect mental health, they are critical in affecting mental health, and stop dividing the body into somehow below the waist and above the waist with hormones. That's not how it works. We've got to look at the holistic approach overall.
Yeah, absolutely. Thank you. So my last question to you, which can either be personal or professionally, if you could tell your 20-something self something, what would you tell your younger self that you know today?
Oh, it's a tough one. Sometimes I regret the amount of time I wasted with self-doubt and not backing the avenue of approach I wanted to take with my work. I wasted some time with that. And had I had a bit more confidence in what I really wanted to do and, you know, where to get to quicker, then I think that would have been better. But, you know, I'm pretty happy with, I'm fortunate. I feel very fortunate that I've had some great mentors. I've had some great colleagues. I've had some great support. I've had a lot of battles, but, you know, you sort of bounce and keep bouncing along, because the cause drives me. The cause is about women's mental health, and we need to improve that, not just for Australian women, but women all around the world, because half the population can't be ignored.
And are there any resources that any of our listeners can use from any of your research centres?
Yes, there is a short course that we've put together. So I maybe will send that to you. I don't have the website address memorized yet, but it's a short course that is our women's mental health. Our centre is called Her Centre Australia, which is health education research for women's mental health. So it's Her Centre Australia, and I'll send you the address for the course.
That's all right. I think we've already got that, so we'll share that in our show notes. And that's directed more at health professionals, is it?
It is, but I mean, there's no restriction, as in, you know, anybody who's very interested can do it. And I don't like to say it's only for doctors or it's only for nurses or whatever. I think knowledge is knowledge, and I like knowledge to be shared. So, you know, people get out of it what they want to get out of it. So I would say, if you're a woman with lived experience of menopause, go do the course. It might help you consolidate your ideas a bit more, or go and help you get your help that you want.
And I know you designed your own questionnaire for the menopause called the MND questionnaire, MNOD. Do you think that's a good thing for patients to download and maybe take with them to their appointment with their GP?
I think it is very useful, because it also shows women that the scope of symptoms is quite large. So people go, but you say this is depression. I don't feel sad. I just want to punch everybody, you know, that rage. And so it's important that, you know, yes, it's menopausal depression is the broad term, but it includes a whole lot of symptoms. And that's something that's useful for women to understand a bit better.
Awesome. Thank you so much for your time today. And thank you for joining us.
Thank you very much. And I appreciate the time you've given me, Shauna. Keep up the good work. We're all in this together.